task here today was to go over the diagnosis, so I'm going to go over those probability models and how they're being implemented in practice, look at D-dimer real quick, and then really focus on the management of VTE. Kind of keep it in mind, the goal really is to reduce the morbidity and mortality, and so we'll look at that with phases of treatment, pulmonary embolus, and then some of the other things if we have time. So, there's several bodies of literature that support use of, in a first patient with a suspected DVT, instead of just doing an ultrasound, to use these pre-probability assessments. And that has not been updated in the new 2021 guidelines. And to look at those prediction rules, there's the Wells, and then that was modified to really basically simplified it from a 3-risk category to a 2-risk category. Then there was a 2 levels Wells score, as well as the Geneva score to look at PE. And basically what this does is it just kind of looks at a clinical scenario and it correlates with a prediction probability of risk of clot. And so with that, if there was a low test probability, the role of D-dimer is inserted here. And if it's negative, you're done. If it's a moderate test probability and you do the D-dimer, if it's negative, you're done. But if it's a high-risk patient, you don't even need the D-dimer, you just need to do the ultrasound. And here again, it talks about a proximal vein ultrasound versus a whole leg ultrasound, which we'll get to again in a minute. So what happened with D-dimer is it's very sensitive, but not specific for DVT. So a value of over 500 has a 95% sensitivity in acute DVT and PE. However, when people are tested for D-dimer, it's not specific for clot. So if you just test the D-dimer, what happens is a lot of folks end up getting extensive workups for clot, which is not necessary if you're not hard with that pretest probability. D-dimer levels in pregnant women have been difficult to analyze, so below are listed some of the recommended levels. And then D-dimers over 8,000 have been associated with malignancy. So what's happening in real time is that patients are going right to D-dimer. A study in 2016 looked at 141 patients that had D-dimer tested. Only 6% had a well score documented. 7%, if they dug through the information, had enough data to calculate a score, but by and large, 86, 87% did not have either of those variables. And multiple studies have showed that people just aren't using the model. It's cumbersome. They don't know how to use it. They think it's unnecessary. They have medical legal concerns. Lee looked at 1,100 patients and said these models were underused. Smith also looked at retrospective data on 97 patients with VTE and found that no pretest probability was done for 62 of those 97 patients. And so these models just aren't really being used. And I think we can see that in our own practice. I've never seen a patient come to my office for a DVT study with a Wells model. And probably if we used a Wells model, we wouldn't be seeing a lot of those DVT patients. And I think it's important to know still in the areas where we work, if people are getting a whole leg ultrasound or just a proximal leg ultrasound, even though the I-cable, IAC requires the posterior tibial, I think the gastroc veins are still kind of optional. This was a case that happened to me. I had a 52-year-old male who was healthy and had just a GSV ablation on a Monday, probably Monday afternoon. By Tuesday morning, he was lightheaded and short of breath. We sent him to the emergency room. He had a PE, and I had a vein specialist there call me and say, this is a classic post-ablation PE. And I said, oh, wow, it's not even been 24 hours. Like, is this vein even closed? And she said, I see it all the time, blah, blah, blah. And I said, okay, well, we agreed to discharge him. And I followed up with him post-op day 3. And he was just starting to occlude his GSV, just starting to feel that tightness on his inner thigh. There was no extension into the common femoral, but we saw this whopper of a gastroc clot. And this obviously was the source of his pulmonary embolus. And this had been missed at that hospital at that time. So here I'm talking to, a cardiologist in charge of their vein center at a University of Michigan affiliate hospital, and they didn't even bother to look, at the gastroc veins. So I use this as a marketing tool as well. I think it's really important that if we're going to isolate out gastric vein clots, that we at least look for them. So if we're going to transition to the goal of treatment, instead of just treating clots, we got to look at what are we trying to do with the treatment. We're trying to reduce the morbidity, mortality. Obviously, nobody wants a PE. They're fatal, lots of complications regarding that. But what about post-thrombotic syndrome? And we know that higher recurrence rates lead to higher incidence of post-thrombotic syndrome. And there's a significant cost to our country. It's estimated that's $8,000 per day for a PE with an average hospitalization of 5 days. Recurrence for post-thrombotic syndrome, that's increased, and that can run $10,000 per year per patient if they get an ulcer, not to mention all the days of work lost. And then a recurrent thrombus is about a $12,000 cost to our healthcare system. Now, what's interesting is isolated caffeine clot patients don't have these problems. They don't tend to have PEs. They don't tend to have recurrence rate as high of a risk. And the risk for post-thrombotic syndrome is very low. And so this allows us to kind of peel them off as a separate category. So when we're talking about management, that's a consideration. Where is the clot? Is it provoked? Is it provoked by what? Is it cancer? Is it not cancer? All these things really have to be considered when we're dissecting out how we're going to treat these veins or these clots. To know the natural history, it's still estimated that this affects 1 to 2 per thousand per year. And again, we have a lot of people with subclinical caffeine clots that don't get registered. So I think this is still a rough estimate. It's assumed that most thrombus starts in the calf, and most caffeine clots are asymptomatic. So it's about 5 to 12% will actually present with symptoms. If untreated, 25% of these will propagate at 1 week. And it's assumed that most of those proximal clots actually started in the calf and propagated up into the thigh. 50% of all patients presenting with VTE are caffeine thrombus. And so if we look at what is the risk of propagation, about 8 upwards to 25% will propagate without treatment. This little graph here shows these patients were left untreated, and 8% migrated to an additional caffeine. So there's propagation into a caffeine. 4% went to a popliteal, 3% to femoral, very few to PE. So the clot can either grow to an adjacent vein or grow north into proximal veins. Schwartz in 2010 said, well, let's give these patients low molecular weight heparin for that 10-day growth window and see what happens. And he found the risk of propagation was unchanged. And it started to peel out this low risk group, did not really need that low molecular weight heparin to be safe. Ferreira also looked at, well, maybe we could treat these patients for 6 weeks instead of 12 weeks, and found that, if there was one caffeine involved, it didn't really matter what your endpoint was. There was no difference in the length of treatment. But if 2 or more caffeines were involved, the propagation was significantly higher if you did a shorter course of anticoagulation. And so that risk of propagation really depends on risk factors. And so many studies have been done to dive into the different risk factors. So malignancy is obviously the highest risk population. Multiple studies suggest that. But there are also transient risk factors. So recent surgery, trauma, venous disease, travel, cardiac disease. These are patients that tend to form isolated caffeine clots, where your cancer patients are going to tend to form the bigger, more proximal clots. Other studies were done that showed bilateral DVT has a high risk of recurrence, high risk of mortality, and is often associated with malignancy. And some studies even looked at how juicy the clot is. The diameter of the clot can influence the propagation and pulmonary embolus risk. Family history obviously was associated with an increased complication rate as well. I think the registry did the best job. Again, these are patients that are looked at retrospectively. The proximal DVT patients, there were 9,000, distal were 1,900. And it kind of sorted out what characteristics or what provoking factors led to their clots. And you start to see that travel is certainly not as risky as cancer. Varicose veins certainly isn't as risky as a history of VTE. And so really dissecting out the provoking factors is important. The Cactus trial then took these low-risk isolated caffeine clots, and it randomized these folks to 6 weeks of therapeutic Lovenox versus nothing. And they analyzed 252 patients, and they found that the low molecular weight heparin was really not superior to placebo in reducing the risk of PE or proximal DVT. And we were subjecting these patients to a higher risk of bleeding, which was 4% versus 0%. And this really led to the American College of Chest Physician guidelines that kind of called back that distal calf DVT and says, we got to think about this. If this is a low risk patient with low risk of extension, just systematically treating all of them might not be the right thing to do. and that surveillance is a safe alternative in these folks. So the current recommendations is if they're symptom-free, it's recommended that you do serial ultrasounds for 2 weeks. And what that really means in practice is that you do an ultrasound once a week. If they're symptomatic, obviously you'd bring them back to do an ultrasound sooner. If there was no extension, then you leave them alone. If there's extension, but it remains in a caffeine clot, anticoagulation was recommended, although the grade of the evidence is not as strong as if it extended into a proximal vein. And if someone's symptomatic, or they have ongoing risk factors for extension, so they have an isolated calf clot, but they have cancer, you're going to go ahead and treat those folks. And if you're going to anticoagulate, there's no indication current time for a shorter course of anticoagulation, even if it's a caffeine clot. So in 2020, the Society of Hematology updated their guidelines. In 2021, CHEST updated their guidelines, and they really kind of start talking about 3 phases of treatment. So you get the diagnosis, and then there's that initial management, which would be your loading doses of Xarelto or your 10 milligram BID dose of Eliquis. Then you treat for 3 to 6 months, and then there's a second decision. Do you continue long-term anticoagulation? And if you do, why are you doing that? And what is your choice for that secondary prevention? So CHEST would say treat for 3 months. American Society of Hematology says 3 to 6 months. Both recommend the DOACs. American Society of Hematology says be careful, if you're using those P-glycoprotein inhibitors with those other medications, which are listed below, because I usually forget those. But really what's important in both of these papers is that they say you got to look at what you mean by provoked. Okay, what do you mean by provoked? And so if it's unprovoked or it's provoked by a persistent factor, then CHEST says at the end of the 3 months, you got to really strongly consider long-term anticoagulation. And use of low-dose DOACs have really come into the forefront as the treatment in that phase, that second phase. The American Society of Hematology says no, continue aspirin or anticoagulation over aspirin. So if they need to be anticoagulated, aspirin's not strong enough. Either low dose or full dose, they waver on that. But they did have a statement that says, you don't need to use those prognostic scores or D-dimers or residual, ultrasounds for residual disease to determine what to do. Those are not helpful. In cancer patients, in 2006, they really wanted people to use Lovenox for cancer patients and not the factor Xa inhibitors. In 2021, that's switched. That's now they're looking at the factor Xa inhibitors are preferred. So that's nice. And to go back to this American Society of Hematology recommending against the use of these scores, I think it is important to know that there are scores out there. There's really 3 that I am familiar with. There's the Vienna, the DASH score. And more recently, there's this Continue 8, which I think is probably the most promising. It had looked at 480 patients with proximal DVT followed for 3 years. There was a 13% incidence of recurrent thrombus, and they have a simplified scoring system. So if it was an unprovoked DVT, that's a big deal. Male sex is a big deal. Factor 8 levels, which I don't usually see drawn, was a big deal. And it divided them into low, medium, and high risk groups. This did not achieve, and it's not been validated enough to make it into the recommendations present day, but this might be something we see in the future. Used to also be that a month after discontinuation of treatment for DVT, especially in men, a D-dimer, it was recommended you check a D-dimer. That's no longer recommended. The D-dimer was also included in the Vienna and DASH models. The problem, as we mentioned before, is that the levels can continue to be high in certain conditions, and that doesn't necessarily mean that they have a new clot, and it's confusing in how to interpret that as a prognostic indicator. Should residual vein obstruction influence a decision? Well, intuitively, I think it should have a role. We'll talk more about that, but if you really look at the data, there was a review of 11 randomized trials that showed there was a correlation. This was published in 2011. There was a review of 9 prospective cohort studies and 5 randomized control trials that did not predict recurrence. In an observational study of 296 patients with the first episode of provoked DVT, it was not associated, residual clot was not associated with an increased risk of recurrence. But again, they're starting to isolate out this provoked versus unprovoked. And I think we really will see those risk factors start to weigh into how we treat these patients long term. What is known is that the highest rate of recurrence occur in the proximal unprovoked DVT patients and pulmonary embolus patients. So a meta-analysis of 7 studies showed the recurrence rate for PE at 5 years was 22% and for DVT was 26%. The proximal DVT had a 5-fold increased recurrence rate over that distal clot. In patients with symptomatic symptomatic PE had a higher recurrence than patients with just proximal DVT. So symptomatic PEs have the highest risk for us, then proximal calf, then proximal DVTs, and then isolated calf. Another study looked at, well, if we continue the anticoagulation longer, does that influence the recurrence? And the answer is no, it doesn't. So the risk of recurrence needs to be considered when you're balancing the risk of bleeding in these patients. So if you have a first clot provoked by surgery, which would be considered, one of those low risk transient risk factors, that is a first year recurrence of 1%, and then over time it's 0.5% per year. Versus if you have an active cancer, your risk of clot is 15% per year. And so when we're dissecting this out, again, like trying to understand if this is provoked by a non-surgical factor, so if they have an autoimmune disease and some inflammatory condition that's causing this, their rate is 5 times that of a recurrence than someone that just had a surgery and got a isolated calf vein clot. And so again, this all needs to be considered. If you look at the relative risk reduction by medication and dose, aspirin's been studied in detail. They studied 100 milligram doses. I think we use 81 milligram doses more routinely. It correlated with a 30 to 40% risk reduction in recurrent VTE. So we'll look at those studies in a minute. Xarelto and Eliquis at those lower doses, if you compare them to low molecular weight heparin in the prophylactic dose arena, that's about a 70% risk reduction versus the full strength, which is over 90% risk reduction. The balancing act here is that the bleed rate is not insignificant. So a major bleed is considered overt bleeding, where over 2 units are transfused, it occurs at a critical site, or it causes death. And Kieran published in 2012, like, hey folks, there's a 2.6-fold increase of anticoagulation if it's continued beyond that 3 months. That we're extending this risk for these patients to what benefit? And so this is the only model that I am aware of that really talks about how do we assess the bleeding risk in VTE patients. We'll look at the models that are out there for hospitalized patients and for AFib patients, but for venous patients, this is about what we have. And if you look, these are the risk factors. And if you have no risk factors, which it's hard to find someone that doesn't have any of these risk factors, you're still looking at a 1.6% bleeding risk. These are major bleeds. All bleeds, so major and minor. And, as these patients get metastatic cancer, right, their bleed risk goes up, so does their clot risk. So these patients are pretty, you have to be considerate of all these factors when you're deciding long-term anticoagulation. And even if you say, hey, we're going to do extended anticoagulation, maybe dropping to a lower dose is more beneficial because you drop your bleed risk, still maintaining a 70% risk reduction. Regardless of what you choose, you need to redo that choice. You can't just prescribe it and walk away. This is something that as people's health changes and the recommendations changes, we need to be seeing these patients annually to reassess what is the appropriate anticoagulation for them. This is the IMPROVE, which is a hospital inpatient risk model. You put in some, answer some questions. It generates a number of bleed risk. The longer version of this is you add up points, and greater than 7 points is risky, and less than 7 is not risky. CASBlood is a calculator for AFib. We see folks running around on blood thinners at 90 years old for AFib, and the risk of a stroke is 1% per year with AFib, but it's a catastrophic event, right? So the mortality and morbidity associated with a stroke is much greater than that for DVT. And so again, that risk benefit ratio really has to be considered when we're looking at long-term anticoagulation. The role of aspirin, to go back to that for a second, aspirin's recommended in patients with unprovoked clots. So again, those folks are going to have a pretty significant risk recurrence. So if they're going to stop anticoagulation, at least try an aspirin. Now, if you really feel that they need to have something stronger than that, then you need to do something stronger than that, because aspirin's not considered as effective, right, in preventing recurrent VTE as the low dose DOACs and full dose DOACs. So in patients offered that extended phase anticoagulation, reduced dose DOACs are preferred over aspirin for that reason. The trials looking at aspirin, so there was a warfarin. These patients were treated with Coumadin, standard treatment, and then put on aspirin. Showed a 41% risk reduction with no major bleeding. The Aspire trial looked at recurrent VTE in unprovoked patients and didn't really see a big difference. And again, maybe these unprovoked patients need to be on the higher dose. Maybe that's what this is suggesting. They did show a composite improvement in arterial and venous disease, venous thromboembolic events. The Inspire, again, looked at aspirin after regular guideline anticoagulation, showed a reduced risk by 42%. So I do think there's a role for aspirin, but again, if we're looking at that unprovoked DVT patient population, I think all this information is kind of pushing us towards the DOACs long-term, at least the lower dose. And to review a little bit of cellular information, we've long understood the role of antiplatelet medication in arterial disease. In venous disease, the platelets express P-selectin. P-selectin recruits these inflammatory mediators. These inflammatory mediators then lead to more thrombus and post-thrombotic syndrome. So in the spirit of keeping with we're treating to reduce the morbidity, mortality, one of the morbidities is post-thrombotic syndrome, right? So it's up to 40% of our patient population can have that after a clot. And what's known as anticoagulation is really the best tool to reduce the risk of post-thrombotic syndrome. When they looked at retrospective studies, historically before anticoagulation and then after the induction of Coumadin and heparin, they saw that there was a 78% reduction in the risk of PTS. But the time spent in that therapeutic range is really important. And we know with Coumadin, about 60% of the time they're in that therapeutic range. The rest of the time they're not, hence the DOACs. That's why the DOACs are preferred. And it's thought that that first month is really crucial. And if we start to look at the cellular level, it makes sense, right? So if the anticoagulants are making that clot more porous, it allows for the natural fibrinolysis to occur. And we'll see that in lytic therapy as well, right? So the non-occlusive clots tended to do better with systemic thrombolysis than the occlusive clots. And it's thought that that surface contact was really important for that. Also, you have to consider, does the duration of therapy prevent recurrence? And then there's new information about the role of statins and the microionized flavonoids. At a cellular level, if you look at post-thrombotic syndrome and recurrent VTE patients, those clots are found to be denser, and those clots tend to be resistant to the fibrinolysis. So Gower in 2020, I thought this article was really interesting. He looked at plasma and clots and spiked it with the different anticoagulants, and then really looked at how that helped that clot dissolve and what happened to pore size and fibers. And it looks like rivaroxabans tended to lead to significantly less dense and more permeable clots, the kind that would be more amenable to fibrinolysis. So what will be exciting to see is from that Garfield trial where they look at all these patients that were on these DOACs, how does that improve the risk of post-thrombotic syndrome? So if this is really happening at a cellular level and that first month is really significant, if we fix those problems with anticoagulation, hopefully that will translate into a reduced risk of post-thrombotic syndrome. Other studies looked at, well, maybe we should just keep them anticoagulated. Maybe that will help post-thrombotic syndrome. So the EXACT trial looked at that very question, does extended anticoagulation reduce the risk or improve the quality of life? So they looked at 281 patients. After 3 months of treatment, they were randomized either to discontinue or continue for 2 years, and there was no difference. Stain looked at the duration for 6 months, 6 to 12 months, or greater than 12 months, and found none of that factored into the risk of post-thrombotic syndrome. And Schulman looked at 10-year follow-ups of 6 weeks versus 6 months and showed really no difference in the risk of post-thrombotic syndrome, but the recurrence rate was lower in the 6-month group. And again, I think that post-thrombotic syndrome kind of speaks to that early treatment is so critical. This led to the recommendation, though, that extended anticoagulation should be offered on the existing guidelines and calculated as a recurrent risk, but not for the sole purpose of reducing post-thrombotic syndrome. So there's also inflammation in post-thrombotic syndrome, right? So this ongoing balance between the pro-inflammatory and anti-inflammatory components and cytokines that regulate this inflammatory response. And we know that platelet and endothelial-derived adhesion molecules all contribute. So when we talk about the role of statins, again, I think this has been well established in arterial disease, but it's shown that statins lead to reduced thrombus size and less venous wall scarring. The mechanism of action is it inhibits those adhesion molecules that recruit those inflammatory cells, so it interrupts that process. And so a study posted in the Journal of Vascular Surgery in 2019 showed that statin use was associated with higher odds of thrombus resolution. Santaberto randomized 234 patients and showed that statin use reduced the rate of post-thrombotic syndrome by about 10%. And there is a SAVOR trial ongoing that is randomizing new VTE patients to standard treatment or treatment plus a statin. So that should be coming out soon. Also, we talk about the flavonoids. There's thoughts that they increase vascular tone, reduce stasis, reduce inflammation. There's multiple studies out there that make suggestions, but I don't think the power of evidence is strong enough for that to make its way into the current guidelines or recommendations. However, there is a MUFFINS post-thrombotic syndrome trial going on that is randomizing these patients to the micropurified flavonoids to see how that affects post-thrombotic syndrome. So that is being evaluated. And then what about lytic therapy? I'm not going to go too deep into this, but should this be used or not? And the idea here was that there was an open vein hypothesis. And so we knew that patients with iliofemoral disease had 2 times the risk of recurrence and 50% incidence of post-thrombotic syndrome. So Prandoni looked at patients 2 years after a proximal DVT and said, if their clot's gone, they do better. If they don't have reflux, they do better. Paul agreed. He did a meta-analysis of 11 patients and found a strong correlation between the amount of residual thrombus and recurrent DVT rate. So this led to the idea of this open vein hypothesis where we should do these surgical thrombectomies and systemic thrombolysis. Albeit that might achieve the goal of an open vein, it alone it has complications of invasiveness, bleeding, etc. So during these trials, it was found that systemic thrombolysis again was found to be more effective in non-occlusive thrombus, suggesting that getting that drug right to the site of the clot is important. And that led to the idea that image-guided thrombolysis infusions wouldn't necessarily propose the same systemic risk and would be directed at the clot itself. So this led to this catheter-directed thrombolytic therapy. Many studies were done and showed, yep, I think it's better. I think it's better. I think there's more free patency. I think there's less symptoms. This led to the CAVANT trial, which did a 2-year follow-up, and it showed the relative risk of post-thrombotic syndrome was reduced by 26%. And then, of course, we're all familiar with the ATTRACT trial that did have a lot of good information come out, showed that there was a greater reduction in leg pain and swelling and severity, but they set the targets for a Velata score at a threshold of 5, and so that specific target wasn't made, but these independent risk variables did improve. Now, in follow-up to that, though, the Journal of Phlebology in 2019 released a meta-analysis suggesting no benefit of thrombolysis after either iliofemoral or femoral popliteal DVT. This was looking at 4 randomized controlled trials were analyzed, and post-thrombotic syndrome was 42% versus 53% in the anticoagulation group. The lytic therapy was not associated with decreased rates of moderate to severe disease, although there was a trend noticed. It was more likely to have patent iliofemoral veins, but this did not lead to lower recurrence rates of future VTE. So based on all of this data, the CHEST 2021 and the American Society of Hematology suggest anticoagulation alone over thrombolytic therapy and catheter-based interventions for clots in the leg. And that was kind of a weak recommendation. I think we're still looking for some definitive data on this, but in severe limb-threatening DVT, patients with phlegmasia or, heaven forbid, gangrene, obviously you're going to try to do this for limb-saving purposes. And the NICE guidelines in 2020 said consider lytic therapy with iliofemoral DVT that persists over 14 days. The patient has a life expectancy over a year, and they're considered low risk for bleeding. So I'm going to transition into pulmonary emboli, the great masquerader. This is the most preventable cause of death in hospitalized patients. The mortality is upwards to 30% if untreated. So if you look at subsegmental PE, this is how we start to talk about this, is defining what do you mean PE. So subsegmental means that there's no involvement of the proximal artery and there's no proximal DVT. If the patient's at low risk, they suggest that these might be observable with just clinical surveillance. In incidental asymptomatic PEs, the suggestion is that the same initial and long-term anticoagulation is recommended. And just to put this in perspective, asymptomatic incidental PEs are found in 1% of outpatients and 4% of inpatients. It shows observational data suggests that whether it's symptomatic or not, it carries a similar prognosis to symptomatic. And these are predominantly cancer patients. I think that the takeaway on that is if you have a PE from a metastatic a cancer, that's a pretty aggressive cancer. And I always think, well, when I'm treating a DVT, am I treating a PE unknowingly? And so what is the incidence of concomitant PE at the presentation with DVT? And this is especially important if we're considering observing isolated caffeine clots, right? So Kieran says about 40 to 50% of patients with symptomatic DVT have a PE, and most of those are going to be silent. Harch looked at 1,300 patients, said about 50%, if it's above the femoral, about 50% of those people are going to present with a concomitant PE. And Kistner looked at 54 patients with, the popliteal and tibial and found that PE was present in about 50% of those folks as well. Tibial vein clots had 33% incidence of PE. This isn't a big group of people, but that's still pretty significant. I think this study in 2004 was the most valuable to me, and it looked at 1,900 patients and it said if you have a unilateral distal DVT, there's about 30% of those, 29% were associated with a PE. Bilateral, though, if you have a bilateral distal DVT, 45%. So that's interesting too, because when we're doing a unilateral study, we're not looking for the contralateral side. And these things tend to suggest that if you have bilateral DVT, you should be considerate of malignancy. And the mortality is significantly different. Now, does it matter if they have a bilateral DVT if you're going to treat them? Probably not. If you're going to treat them, it probably doesn't matter. But if you're not going to treat them, it might be significant. They did do surveillance studies on patients with isolated caffeine clots, and so they followed them with VQ scans. The studies that were published all had the patients anticoagulated, but it showed between a 0 and 6% incidence of concomitant PE in those patients. Now, the management of PE is the same as treatment for DVT. They're all on the same thing. But the question for PE is, do you do it as an inpatient or an outpatient? And outpatient anticoagulation is safe if the following criteria are met. There's a low risk for death, they're not on narcotics, they have access to healthcare, they're competent, and they don't have a lot of comorbidities. The 2021 recommendation was that outpatient treatment over hospitalization, if they're clinically stable, there's no contraindications, they're going to be compliant, they're well enough to be home, and they have access to healthcare. So most of the guidelines suggest that they should be treated as outpatients. And how do you randomize who's supposed to be treated as an outpatient? Well, this is based on the Pulmonary Embolus Severity Index. Okay, this was published in 2005. It's the gold standard for risk prediction. It was pretty complicated when it started, so it got everything else gets simplified. And basically, if you're over 80, have cancer, pulmonary disease, low blood pressure, low SATs, or high pulse, then you're at high risk. Any one of those things puts you in a high risk category. Otherwise, you could basically be treated at home. And the mortality of this group was 3.5%. So this study was published in Lancet in 2011, and it took these patients in this low 1 and 2, the low risk categories, and it randomized them to either outpatient treatment or inpatient treatment. And basically one person died in each group. There was 2 major bleeds in the outpatient, but clinically there was no clinically significant difference between these 2 groups, suggesting that in this low risk group, it is safe to send them home. Another study was published in 2015 that said, well, what about troponin? I mean, maybe that's a predictor of this. And they looked at 300 patients with PE. They drew troponins, and they found that if not detected, if troponin was not elevated, none of those patients died. And if detected, 6% died. And so maybe this is a better predictor of risk. What's actually happening, though, this is from 2008, is only less than 15% of eligible patients are actually being managed as an outpatient. And if you look at why do we care? Well, it's the cost of our healthcare system, right? So it's $8,000 per day is the average cost. Average admission is 5 days. It would be $1 billion a year of savings if all those risk patients were treated as an outpatient. What about thrombolytic therapy? The only indication for this is if someone is hypotensive, so shocky, without high bleeding risk, and it's systemic thrombolytic therapy. If their blood pressure is over 90 or non-shocky, they recommended against it. And the other indication is patients who deteriorate after anticoagulation therapy. So they're declining. They just haven't developed hypotension yet, and they have an acceptable bleeding risk, then sure, you can anticoagulate those. But it's systemic thrombolytic therapy. NICE 2020 recommended in hemodynamically unstable patients. Again, you can use systemic thrombolytic therapy. What about catheter-assisted thrombus removal therapy? This acute PE treated with thrombolytic peripheral vein over catheter-directed. So they are against catheter-directed. Now, in acute PE patients with hypotension, high bleeding risk, who have failed systemic thrombolysis, and shock and death is imminent, go ahead and do that. Now, interestingly, I had a patient at Muskegon who had a PE. He had right heart strain on an ultrasound, big, heavy guy, probably had right heart strain just because of his weight and his other comorbidities. They took this guy with no oxygen desaturations, no tachycardia, nothing, just right heart dysfunction, and they did a catheter-directed thrombus removal. So that is not the standard. I mean, I don't think that's what's being practiced, even though these are the recommendations. I think we still see a more aggressive approach to these PEs. Thankfully for that guy, it worked out. We're going to go into phlebitis. Eddie did a really great job with this not more than a couple weeks ago. So again, the incidence is estimated. It's about 11% incidence, and we don't know because we don't know how many people don't seek medical treatment. And, you know, if you have phlebitis in a varicose vein, you think, well, it's probably the varicose vein. If you have phlebitis without the varicose vein, you got to start to think of other things, like what provoked that? Autoimmune cancer, thrombophilias. Remember migratory thrombophlebitis, you got to think of pancreatic cancer. And phlebitis can happen after IV infusions, so it's not insignificant. And we'll talk about upper extremity clots in a minute. So this is a patient that presented to me. He had phlebitis, wasn't really angry even. But, you know, 1 out of 10 of these folks have a DVT. So here's the phlebitis. Here's it going through the perforator. Here it is in the posterior tibial vein. And so as Eddie recommended, you know, treating these patients with segments over 5 centimeters in length is recommended. If the phlebitis extends up to the common femoral or the popliteal, I tend to treat them as a DVT. You'll also find that the DOACs have a nice anti-inflammatory effect. So starting these patients on those will help with that inflammation and dial down their pain. And then I think Peter had mentioned in that lecture by Eddie too, you know, don't be afraid of doing a thrombectomy if patients are super symptomatic. We got a ton of clot out of this guy. Helped him a ton. Upper extremity DVT, when you're talking about that, if you're in the proximal would be axillary or more proximal veins, they suggest anticoagulation over thrombolysis. And these are our patients that have indwelling catheters, right? And they should undergo the same anticoagulation even if they get that open. So I've seen how many patients that have a cancer with an occluded catheter where they get lytic therapy to open the catheter and subsequently open that, and they don't go on anticoagulation. That's a no-no. They need to be anticoagulated. And it's estimated that over 5 million central venous catheters are placed annually in the United States. So 30% of people will develop a clot with a central line. When PICC lines became popular at our institution in Grand Rapids, our nutritionist we were putting these PICC lines in under ultrasound guidance, and he found that 30% of those patients had a clot from that PICC line. 50% of femoral lines will develop a DVT, and remember, central venous catheters are an independent risk factor for clot. What happens if you get a recurrent VTE on anticoagulation? Well, your first suspicion is it a recurrent clot? Is that just a clot that never went away? I tend to do those follow-up ultrasounds to have that information to understand, is there residual thrombus in that vein? Because, you go to the hospital and they say it's it's non-compressible, so it's a clot. They don't necessarily always age it. So having those follow-up images helps me to determine whether it's recurrent or not. So I tend to do that at 3 months. But the bigger thing is compliance. What happened with Coumadin is you could actually check the level. With the DOACs, you assume that they're taking it. I've had a couple patients that say, nope, I don't think I missed any doses, or maybe I missed one dose and they have a new clot in a new area. It's challenging to know what to do with those folks. The current recommendation is, reevaluate whether it really was recurrent, evaluate the compliance, consider another driver, another force behind that, so an underlying malignancy. These are patients that I'll automatically refer to hematology. And if they have recurrent VTE, you should switch them to Lovenox. If you switch them to Lovenox and they're compliant and it's still not, and they're still clotting, then you're supposed to increase the dose by 1/4 to 1/3. IVC filters, again, really the only indication is an acute clot with an absolute contraindication to anticoagulation. It'd be great if those filters were retrieved once that risk goes away. And if a person has a filter, that doesn't mean you don't have to anticoagulate. You certainly do want to anticoagulate them as soon as it's safe to do that. In closing, again, let's look at that beautiful coagulation cascade. Here's your factor Xa inhibitors coming in, apixaban and rivaroxaban. You have Pradaxa as a thrombin inhibitor, okay, in that common pathway. And the summary of anticoagulants, I see this all the time where people don't get this loading dose of Eliquis, or they don't get the loading dose of Xarelto. But these are the doses, right? And these are the prophylactic doses. In summary, we all know all this stuff already, but this just kind of summarizes the risk-benefit ratio of all of these different anticoagulants. I think one of the drawbacks of the DOACs initially was that it wasn't reversible, and I think a lot of the hesitation that I saw in implementing its use into clinical practice was because, gosh, what if I start bleeding? I'm stuck with that for 2 days. Well, there are reversal agents, okay? So Adnexa is good for the factor Xa inhibitors. This thing is expensive. It's $25,000 to $31,000 to treat a patient with this. And Praxbind is less expensive, and it works specifically on Pradaxa. So the reversal agent for Pradaxa is actually better, I think, than the factor Xa reversal agents. I've seen some patients that have to have a dual therapy, like blood thinner plus aspirin, and I see that the hematologists are more likely to give Pradaxa in that case than Xarelto. And I think it's because of this reversal agents. So the different reversal agents are expensive. They are limited to very emergent situations. These are not readily available in every hospital just due to the cost and the shelf life of these. But basically, this is the algorithm. If a patient's on a DOAC and they're not bleeding, even if they're in a trauma, it doesn't matter. If they're overdosed, doesn't matter. You just hold tight. If they're bleeding, you have to decide, is this life-threatening bleeding? If it's life-threatening, and life-threatening means to a critical organ, a major bleed that's not responsive to massive supportive measures, or let's say it's a head bleed, then you can do the reversal agent for those folks. But it is very limited and restricted use of that due to the cost, simply the cost. So that concludes our discussion today. I'm open for any questions that you all might have.
So thank you, Laura. I have to say, this is the one lecture I kind of look forward to every year because I know you always update it and add new information to it. So for the fellows, let's try to sort through some of the common scenarios. So you mentioned capping DVT. So let's say we have someone with a short segment PTV clot, asymptomatic, it's in the middle of the calf. and then they have no symptoms, follow or anticoagulate them? Laura, do you hear me?
Oh, you want me to answer?
Yeah. I want
So,
you-
so I thought you were talking to fellows. So in an isolated calf vein clot, I would ask, well, why do you have that? Are you in a boot and immobilized and going to plan to be immobilized for the next 6 months? So if that's a persistent factor, I'd be more likely to anticoagulate them. If they're completely asymptomatic, they have no risk factors. This is just something that happened after a flight from Florida, then I'd say no. So I would look at, well, why did this happen? If I can identify why it happened and that risk is passed, then I would say no, I would do a serial ultrasound on them.
What about if it's proximity to a junction, say saphenopopliteal or a saphenofemoral?
So if it's within a couple centimeters of that, I think, again, I would go back to the risk factors. The literature doesn't say that. You know, that one study I showed you where they separated out high-risk patients and they anticoagulated, they randomized them to anticoagulation. They did exclude patients with clot at the trifurcation. So they did consider that a high-risk group. So that does sort out to be a higher risk group. In that patient population, again, if they're a low bleeding risk and I would probably more likely to anticoagulate just based on the proximity to that.
And I would also add, like the patient that you said, a large gastrocnemius clot that's close to the junction. I think that's another high risk group that should be anticoagulated.
Yeah.
In terms of length of anticoagulation, you went through all of the different studies and all the different recommendations. I'm always stunned at the fact that duplex ultrasonography is not part of the decision-making tree.
Yeah,
So,
I agree.
So, I mean, I use duplex to kind of help me make my decisions. So if I've decided to anticoagulate a calf vein DVT, and by six weeks it's gone, then I tell them that I usually just do it another 6 weeks for recurrence purposes, but I don't treat those more than 6 to 12 weeks.
Yeah, I agree.
That's based on the duplex finding, and if they're asymptomatic and, like you said, transient risk factor and all that, what's the point of extending it longer?
I agree. I totally agree with you, and I think that's a real opportunity for us because I practice the same way. So I'll bring all my patients back with the clot at 3 months, and if there's still a big chunky clot there at 3 months, I'm going to keep them on that for 6 months and reassess it. If it's gone, it's done, and so I do use that as an indicator as well.
Another comment you made was on the kind of the fresh thrombus. And the one paper that I always sticks in my head is that paper by Prandoni that showed when they were using Coumadin, and as you mentioned, if the therapeutic levels are not there, those are the people who have the poorest recanalization rates. So the clots that I usually struggle with in terms of decision tree is the femoral vein clot. So your popliteal vein is not involved. You have a symptomatic femoral vein clot. It's very rare for me to treat them less than 6 months because by duplex, they're rarely, gone completely. So then I know that the chest guidelines say at 6 months, you can probably safely stop it. I've never really, most of the time I'm treating these patients for 12 months just because the duplex ultrasound shows that the recanalization hasn't occurred. And I want to give them their maximal possibility to kind of open that vein as much as possible. So what are your feelings about length of treatment after 6 months?
I agree with you, but when you look at the recanalization rates, like 90% of the recanalization happens in that first 6 month window. So when I looked at that data, the likelihood of it changing from 6 months to 12 months is a lot less than it changed in the 1 to 6 month. So that's the thing, that if that extended anticoagulation led to higher patency rates, but I've never seen an article that says that longer use of anticoagulation, if you look at all those post-thrombotic syndrome studies, for example, you could extrapolate from that. It didn't address patency itself, but presumably patients that have occlusive thrombus and residual occlusive thrombus are going to have higher post-thrombotic syndrome rates.
Yeah, and I'm wondering if that observation is true because by 6 months you've probably got axial transformation of the profunda, and the profunda is taken over by then, and the flow is not necessarily directed primarily through the femoral vein. But Fernando has a question. Go ahead, Fernando.
Hey, Laura, that was outstanding. Let me ask you, what are your views, or how do you handle Varithena-induced gastroc vein thrombi?
So I just had one of those, and I put them on a prophylactic dose of Xarelto, and I just tend to prophylax them for the rest of their treatment. And when they come in, I just do serial ultrasounds. So I usually routinely will put people on a low dose aspirin for treatment. And if they're this guy in particular that I'm thinking about, he had pretty juicy gastroc clot coming right in through a perforator, kind of petered out and got P throm as it moved towards the junction. It's about 4 centimeters from the junction. But it was only 7 days after. You know, I've seen patients develop clots or occlusion down the road here from these varithenas. So I am tending to treat them with a prophylactic dose.
What do you do, Fernando?
Yeah, I have I divide them into symptomatic and asymptomatic. If I on follow-up incidentally find it and they're asymptomatic and smallish, I just follow with serial ultrasounds. If they're symptomatic and the gastrocs are juicy or full, then I give them Xarelto, fully anticoagulate them, and then follow them to disappearance. And typically within 3 months, those disappear. And then I will stop it and then follow up with ultrasound. So I have a decision tree, symptomatic, asymptomatic. But it's interesting that you use prophylactic doses. That certainly decreases, any risk of bleeding. So
well, but I'm coming back at this guy, right? He's got multiple treatments also. So if I was like, if I just found that and we were done with treatment, I'd probably be like, okay, well, let's just see how that goes. Again, if they're asymptomatic, this guy was asymptomatic, but I'm like, I'm gonna keep creating inflammation in your leg to finish this treatment. And I just didn't feel comfortable. I was kind of trying to hedge my bets between, he doesn't really need full anticoagulation. There's no indication for that, but to just do aspirin and expect nothing to happen when it happened on aspirin isn't enough. So that's how for that particular patient,
I will usually, that's a good thinking. What I do is pause my treatment plan, see how they do, and then continue. But I like that kind of hedging bet and doing both. Yeah.
So I have to say, I do the same thing that Fernando does, but I rarely treat them more than a month, because when I bring them back for the serial ultrasounds, they're usually gone by 4 weeks.
Right. I agree.
Seema, you have a question?
Yeah, actually, that was my question, is that if you see resolution of that post-treatment clot before the 3 months, do you stop? And you just answered that. So thank you.
Yeah. And my feeling is that all of those clots we know were provoked. There's something that we did, and they tend to be short and focal clots. And most of the time, like Fernando said, they're asymptomatic, but there's a case. But one of the things about varithena that I found, especially in the superficial veins, it causes an intense inflammatory reaction, and it's very uncomfortable, especially if you don't use the noodle and the compressor. It's even worse. So the anti-inflammatory effect is one of the reasons why I put them on. It just didn't minimize the pain that they're feeling after varithena-induced thrombosis.
And that's a good point, Peter, with regards to the inflammation can occur 1 week or even 2 weeks afterwards, depending what you're doing. And that, I was on call last night, and I just had a phone call identical to that, a week and a half, 2 weeks after varithena, and the patient's having pain, and the patient was very concerned about blood clot, as we all should. But that delayed inflammatory response is so typical with varithena, at least in my experience.
Yeah.
I just had a follow-up question, if I may.
Sure.
This is Seema. So how about if that clot recanalizes before the 3 month, but there's still some residual clot, the patient's now asymptomatic? Would you continue for the 3 months just because there's residual clot burden, or you'd base it on the fact that it's recanalized? It's okay to, and symptoms are resolved, it's okay to stop?
The literature, I would suggest you could stop it. I don't think you need the extra. I would stop it. I mean, if we get, let's say it's just a scleral clot, right? I mean, I do tons of scleral, and I see PTV clots twice a week. I mean, they happen, and trying to discern in that patient population, well, what's this going to do? Most people don't have that, but at this group that has it, I just have a real frank conversation. And if they have symptoms, I treat them for a month. At their 1 month follow-up, the clot's always gone. At 1 month, it's always gone. And so I was, and the reason I only treat for a month is because, if you go back to one of the things earlier is that first month is really critical. And if these DOACs are making this clot more porous, right, and it's allowing the natural fibrinolysis to occur, and that's occurring early in the development, right? That's not going to occur at month 8. That's going to happen in month 1. Then I want to give them the best opportunity for that thing to go away. And just like Peter said, those things are always gone.
Yeah, great, thanks.
They're always gone. But I think that I'm hopeful that Garfield literature, I mean, when you look at what's happening at the cellular level, that study in 2020 was really interesting just to see how the different medications are chewing up that clot, and changing the porosity of those clots. And so I hope that with that Garfield registry, it'll show us that, maybe an isolated caffeine clot treatment for 1 month is adequate because the clot's gone. And, I think there's a lot of opportunity here, Peter, like to look at these caffeine clots and the use of this for a month and shorter duration therapy.
Yeah, I'm actually very interested in looking at these foam-induced thrombi because I think there's not a lot of good literature on it. And I think the literature is very a mixed bag on it. And we certainly do so much of it with our surveillance scanning protocol. We, I think, can make a significant contribution in that regards. But listen, it's almost 8 o'clock. I have one last question to ask you, and then I'm going to let everybody go. You also mentioned a unprovoked DVT being associated with possible cancers.
Mhm.
So if we worked up every DVT patient we saw for a cancer, we'd be doing nothing but workups on this. So who do you kind of focus in on and say, listen, you know what, you're in a high risk group, you should be considered to look into whether or not you have a possible malignancy?
So the guidelines suggest that you just do a age appropriate cancer screening, not necessarily a witch hunt, just age appropriate. So, if you're past due for a mammogram or colonoscopy, or that's all I do. If they have some crazy big clot.
If you're in the age group, but you also have risk factors, for example, if you have a smoker, if you have a history of cancer in the family, or if you have a personal history, those are the kind of, or like, then I'll ask them some questions. Have you had weight loss? Have your stools changed? I just kind of do a quick screening. And if they tick off any of those boxes, then I usually call their primary care or suggest to them that they not ignore this and that they, kind of get, like for males especially, just get a PSA. It's quick, it's easy.
Yeah.
All
Yeah,
right.
I think of new DVTs, I think 20 to 30% of them have a malignancy, so it's not insignificant.
So again, thank you, Laura. Like I said,
Yeah,
this is
you're
one of
welcome.
my favorite lectures of the year. You do such a great job with all of this.
Thank you.
Everybody have a great weekend. And
Have a good weekend.
Aditi, I hope you paid attention to this. If you didn't, ask Dr. Kelsey for the slides, or we'll have Stephanie send them out to everybody, because there's a lot of literature that she went through there very quickly. So believe me, there's a lot of things to read in that slide presentation. So thank you very much, everyone.
All right. Thank you, guys. Have a good day.